A 33-year-old woman with sickle cell disease is hospitalized for pain control. Initially, she was stable, but soon after, she developed shortness of breath, cough, and a fever of 38.9 Celsius. Her O2 requirement jumps, and a repeat chest x-ray shows bilateral patchy lower lobe opacities. You are managing fluids. What is the next most appropriate step? A. Administer hydroxyurea. B. Initiate ketamine. C. Start a heparin infusion. And D. Start antibiotic treatment. Take a second to answer this question. The answer is not going to be A. Hydroxyurea has been shown to reduce the incidence of acute chest syndrome, but it is not indicated in acute treatment. It's not going to be B. Initial pain control in sickle cell patients should be with opioids. If a patient has severe pain that cannot be controlled with opioids alone, then we can consider ketamine as an adjunct agent. Not C, because therapeutic anticoagulation with heparin is not going to be indicated in treating ACS, because vascular occlusion is secondary to sickle cells rather than a thromboembolic process. The correct answer is going to be E. We're going to be initiating antibiotic treatment. This patient has ACS. It is very serious. It is a leading cause of death in sickle cell disease, and it presents with new pulmonary infiltrates, fever, and respiratory symptoms, often triggered by a vaso-occlusive crisis or infection. And for the priorities in the management, we want oxygen and fluids to prevent hypovolemia. We want to start empiric antibiotics, typically a third-generation cephalosporin plus a macrolide to cover strep pneumo, mycoplasma, and H. flu. And blood transfusions can also be considered to maintain a hemoglobin level above 10, which increases the oxygen carrying capacity of the blood and reduces the concentration of hemoglobin S. So remember, new infiltrates plus fever in a sickle cell patient. Think of acute chest syndrome. Don't wait and start antibiotics early.